Hello, everyone. Thank you so much for joining us tonight. Tonight, I'm excited to introduce Dr. Umberto Campia. Throughout his presentation, you can send any questions that you may have through me to the question button that you should see right on your screen, and we'll answer those in the last 30 minutes or so of the hour. All right, Dr. Campia, take it away.
Okay, perfect. Good evening, everybody. This is Umberto Campia, one of the cardiologists and vascular medicine specialists at Brigham and Women's Hospital. And tonight we're going to talk about peripheral arterial disease. And the second part of the title is what your legs can tell you about the health of your heart. So we will not just consider the manifestation of atherosclerosis to the legs, but we are going to expand also to the risk of having a heart attack or a stroke, which is associated with blockages in the legs. So, first of all, we need to give a definition of what peripheral arterial disease is. And when we talk about PAD, we usually talk about the peripheral disease in the lower extremity. And this disease is caused by the occurrence of atherosclerosis, and I'm sure that everybody is familiar with the fact that it is a buildup of cholesterol plaques in the arteries, which are the vessels that bring the blood from the heart to the tissues, in this case, to the legs. And the vessels that are considered part of the peripheral arterial disease of the lower extremities are the aorta, the iliac arteries, the femoral arteries, the popliteal arteries, and the arteries below the knee, which, just for the sake of completeness, are the anterior tibialis, the posterior tibialis, and the peroneal artery. Now, we've talked about atherosclerosis and the buildup of the cholesterol plaque. But I think we can have a little bit more of an understanding if we look at this video that I'm going to play right now. And let me know if you don't hear well.
When you have atherosclerosis, a fatty material called plaque builds up inside the walls of your arteries. It's a problem because it can reduce or completely block blood flow and lead to a heart attack or a stroke. No one knows exactly why it happens, but scientists think it begins with damage to the inner wall of an artery. It can start as early as childhood. It starts when things traveling in the blood, like cholesterol, fats, calcium, and waste products, collect in the damaged part of the artery wall. With all of it bunched together, chemical reactions start to happen with your body's bad LDL cholesterol. This triggers inflammation, and cells at the site release chemicals that call for help. Your immune system sends white blood cells to the damaged site. They begin to eat the cholesterol. This sounds good, but it isn't. The cells change into foam, and those foam cells form plaque. As the plaque increases, the artery wall thickens and hardens. At the same time, muscle cells in the artery wall start multiplying, and they move to the surface of the plaque. They contribute to the problem by forming a hard cover or cap over the plaque. Eventually, the artery narrows enough to reduce blood flow, which reduces the amount of oxygen nearby organs can receive. Over time, the cap may break open and release all this plaque into the bloodstream. It can flow downstream in the artery and form a blood clot, which can stop blood flow altogether. When that happens, blood supply becomes limited to the areas around the clot. If it happens in your heart, it causes a heart attack. If it happens in your brain, it causes a stroke.
Okay, did everybody hear well the video, the sound? Okay, so one thing though that in this video, and this is very common, is that they mention the coronary arteries, the arteries of the heart. They mention the stroke, which so is the carotid arteries usual, but oftentimes they don't mention the arteries to the legs. And that's why we need to spread more awareness that also those arteries are affected by atherosclerosis, and they represent an important health problem. Now, how do we know when we have blockages in the legs or we have peripheral artery disease? So the typical clinical symptoms of peripheral artery disease is called the intermittent claudication, which is a Latin way to say there is a on and off limping. Typically, the claudication is described by the patients as this pain or an ache or cramping in the calf or in the thighs or in the buttocks that occur when walking, and that goes away when the patient stops, when the walking stops. However, as we can see in this slide, if we take a group of patients that have proven blockages in their legs, only about 10 to 30, 35% have the typical symptom of claudication. About 20 to 50% have no symptoms. They're not really aware of any problem. About 30, 40% report symptoms that are quite vague, not typical, some pain at rest, some pain that occurs when they walk but doesn't go away when they stop. And luckily, it's only a small number of these patients present with severe blood flow problems that manifest what we call this critical limb ischemia. Still, this can occur, and oftentimes I see patients in clinic that are referred to me after being evaluated by multiple specialists, and sometimes it is too late to salvage a toe or to salvage a foot because the damage is already done. Now, even if patients have no symptoms, the presence of blockages is associated with abnormal function of the lower extremity. So patients, even if they don't feel pain, they can walk less, they can exercise less, and they become more and more disabled in time in much faster way than those that don't have the blockages in the vessels. Now here, if we can see in this graphic that the symptoms of peripheral artery disease depend on where the blockages are. So if we see on the top left, the buttock and hip, usually they are associated with blockages in the aorta or in the iliac artery. Just last week, I saw a gentleman that was complaining of this pain in his buttocks and in his hip that was severe. He could walk only about 100 feet before he had to stop. And when he stopped, it would go away. I ordered an MRI, and the MRI showed that he had complete occlusion of the iliac artery, common iliac artery on the left leg, and a 90+% blockage in the iliac artery on the right. So oftentimes, just by hearing the history, we know where the problem is, and we can order a specific test. In that case, I order an MRI of the abdomen and the lower abdomen, the pelvis. Now, if the patient reports pain in the thigh, usually, as I mentioned earlier, is the aorta or the iliac arteries, but it can also be the common femoral arteries, which is the artery at the top of the leg in the groin. If the further down we go, if the pain is in the calf, it can be from the superficial femoral artery if it is in the upper calf, or from the popliteal artery if it is in the lower calf. If the patient has pain in the foot, usually is due to blockages in the arteries below the knees. We have to keep in mind, though, the blockages can occur at different levels. So we can have a blockage in the aorta or in the iliac artery, and a blockage in the superficial femoral artery, and a blockage in the arteries below the knee, such as the anterior tibial artery. So we always have to keep in mind that the blockages can happen in any vessels and can cause symptoms at different levels of the legs. Now, if I briefly mentioned earlier critical limb ischemia, which is a severe manifestation of the blockages of peripheral artery disease. Usually when a patient presents with a pain at rest, in this aching or that occurs even if the patient is not walking, or if the patient has an ulcer, or even a gangrene, death of the tissue, usually is due to the presence of blockages at different or multiple levels. So from the aorta to the iliac to the femoral and to the arteries below the knee. In critical limb ischemia, we will see is a very dangerous situation and is associated with high risk of amputation or even death. Now, how common is peripheral artery disease? Well, we first have to keep in mind, how do we define peripheral artery disease? I mentioned earlier that a significant number of patients with peripheral artery disease, even those that may have more than mild disease, don't have the typical pain, and so they don't know that they have it. But also, they may not be able to report pain because they have other issues going on. Many times patients have arthritis of their knees or their hips, and they are not really walking. They're using their electric scooters. So at this point, they're not walking, they're not developing symptoms of PAD, and the diagnosis can be completely overlooked. Or they may think that the diagnosis may be due to their knee pain. Now, how do we diagnose PAD in a more accurate way? And we can see here, this is a current modern system that looks at different ways, the blood flow in the vessels and the pressure, different levels. But if we think about it, the diagnosis of peripheral artery disease is relatively simple, and we just have to think about hydraulics. Now, I put this kinked hose because it's what really happens. If you have a normal water hose and you are watering your plants, you usually have a good pressure coming out of the hose, and the water can reach, a plant that is a few feet away. But if there is a kink that narrows the passage of the water through the hose, then you can see that the stream becomes weaker and weaker, and the pressure drops, and you can only water the plant that is next to your feet, if at all. So this is what happens in our circulation. Our vessels have pressure in it, and the presence of a blockage is going to affect that pressure. So here we can see that to diagnose peripheral artery disease, now we use the ankle brachial index. In the past was called ankle brachial pressure index, in which we just measure the pressure at the level of the ankle and at the level of the arm. Why do we measure the pressure at the level of the arm? Because usually the arteries in the arm don't get blockages as often, so it's less likely to have blockages. That still, it can happen, and that's why we need to measure the pressure in both arms, not just one, and make sure that we use the higher blood pressure. And then we measure the pressure at the level of the ankle. And as we can see here, let's say if a blood pressure is 120 in the arm, and we measure the blood pressure at the ankle is 132, the ratio is 1.1, which is completely normal. In a healthy person, the pressure at the ankle should be a little higher than the pressure at the arm. So the ABI, the ankle brachial index, should be about 1.1 or so. Now, if there is a blockage, as I mentioned earlier, the pressure drops after the blockage. So if it is 120 before the blockage, after the blockage it can be 90 or even lower. The worse the blockage, the lower the blood pressure. So as we can see here, if the blood pressure is 120 at the arm and is 90 at the ankle brachial index is not 1.1, but is 0.75. And now we consider diagnostic of peripheral artery disease an ankle brachial index of 0.90 or less. So if a patient has a test and it has an ABI of 0.7, that's peripheral artery disease. Now, when we use the definition of peripheral artery disease with an ABI of equal to or less than 0.90, how common is peripheral artery disease? Unfortunately, peripheral artery disease is very common and underdiagnosed. In the US alone, PAD is estimated to affect about 8.5 million people from the age of 40 and older. And as I mentioned earlier, has significant impact on the quality of life and also, unfortunately, on mortality and stroke and heart attacks. So when we look at different age groups, at age less than 60, the percentage of people with PAD is relatively small, 2-3%. But when we go up in age, above the age of 75, we can see that it is more than 20-25% of people. And this is also important to mention that African Americans tend to have a much higher, about twice as high as white Americans, as Hispanics and Asian Americans. And this is not known why. Now, unfortunately, patients with peripheral artery disease, even when they have no symptoms at all, have a significantly increased risk of cardiovascular ischemic events, meaning events due to reduced blood flow to an organ, particularly heart attacks, myocardial infarction, stroke, and cardiovascular death. Usually is due to a irregular rhythm of the heart, sudden onset of a severely irregular rhythm of the heart that causes a sudden death. Now, patients with severe peripheral artery disease, besides having a risk of increased cardiovascular events, also have a risk of limb events, particularly the need for the opening of blockages because of the presence of pain, or unfortunately, the need for amputation because of loss of tissue, of vital tissue, due to decreased blood flow. Now, in this graph, we can see that patients who have peripheral artery disease And here, the ones that have no symptoms are depicted with the red line, and those with symptoms are depicted with the blue line, have a much lower event-free survival, meaning being alive without having had a heart attack or a stroke at 5 years, compared to those who have no diagnosis of peripheral artery disease, or that we don't know if they have it. So peripheral artery disease that is asymptomatic is already associated with worse risk of having a heart attack or a stroke, and having symptoms increases that risk almost twice as much. And this is because usually when you have symptoms, you have more blockages, more severe disease. In this slide, this next slide, we can see a similar distribution, but based on the values of the ankle brachial index of the ABI. As we can see, if a normal ABI is considered between 1.1 and 1.5, even a mildly reduced ABI of 0.9 to 1.1 already is associated with a higher risk. And then the lower the ABI, the higher the risk, so that if your ABI is less than 0.5, you have a 50% chance of having had a heart attack or a stroke in 5 years. Now, if you have critical limb ischemia, you are even at higher risk. So if we see on the left, we can see that patients who present with primary limb ischemia, about 25% unfortunately need amputation when they present. About 50% need revascularization, meaning opening up their vessels when because they have symptoms. And only 25% are going to be treatable with medications alone. And if we take this whole group of patients and we follow them up for 1 year, about a quarter of them will be dead in 1 year. About 30% of them, I apologize, this is a wrong number, will have an amputation. About 20% will have still symptoms, and only a quarter of them will be better off. So critical limb ischemia is as deadly as some forms of cancer. Now, if we think about it as a preventable disease, what are the risk factors that promote the development of peripheral artery disease? Now, the first one, unfortunately, is aging. And then we have diabetes. Then we have high blood pressure. Then we have high cholesterol. Then we have smoking, chronic kidney disease. Also, there is a strong familial predisposition and racial predisposition, particularly, as I mentioned earlier, being African American. Now, these are all risk factors also for heart attacks and strokes. It's interesting that patients who have peripheral artery disease have, among the risk factors, 3 are considered the strongest. The first one is aging. So, as I mentioned, every 10 years of increase in age, the risk of peripheral artery disease increases by 1.5 to 2 times. The other risks are diabetes and smoking, and each of them on its own increases the risk of PAD by approximately 3-fold. Now, how do we treat peripheral artery disease? So the first goal of the treatment of peripheral artery disease is to improve the symptoms when they are present, to improve quality of life, which we know is affected, and to prevent amputation, which is always a risk. The first thing we need to do is discontinue tobacco. And this is one of the most challenging approaches, because tobacco addiction is extremely strong, and it's always a challenge. Walking, staying healthy and being active always helps. We can use a medication called silofazole. It's the only medication that has a modest effect. Also, it has significant side effects, such as a headache or stomach upset or nausea, diarrhea. In only about 40% of patients that started are still taking it, are still taking it after 1 year. Then we should always maintain good foot care, so prevent damage from abnormal, from unfit shoes, and from particularly in diabetics. And if needed, we can use revascularization. Now, as I mentioned, the patients with PAD have have a high risk of heart attacks, of stroke, and cardiovascular death. And the measures to reduce these risks are obviously to discontinue tobacco, walking, then good blood pressure control, particularly with a class of medications called ACE inhibitors, such as lisinopril or enalapril. Then high-dose statin therapy, which is a medication to lower cholesterol. And now we also have a new treatment to lower cholesterol that has a different mechanism of action that also has been shown to reduce the risk of heart attack and strokes and amputation in patients with peripheral artery disease. And then we need to take antiplatelet therapy. And more recently, we also know that taking a low-dose blood thinner, such as Xarelto, reduces the risk of heart attack, strokes, and of amputation. Now, if a patient takes their medications, the risk of having a cardiovascular event goes down. And we can see here that if patients are taking all the guideline recommended therapy, the aspirin, which is an antiplatelet, the statin, the ACE inhibitors, and they quit smoking, they have, and we can see in the blue line, a lower risk, about half the risk, as those who are not taking all of their recommended therapies. And the same is not just for strokes, but also for amputation. We can see here that those who take all of the medication have a much lower risk of needing a revascularization, a bypass, or stent, or undergoing amputation. Now, when a patient has been treated with medical therapy and still has symptoms, there are additional options, and these are the invasive options. And the indications are either still significant symptoms despite the medical therapy. And as I mentioned earlier, my patient that I diagnosed last week that has the bad blockages and that has the pain in the buttocks and in the thighs when he walks, I've referred him to my colleague to have stents placed in the iliac arteries to open them up, because he is a very active person, but he cannot really conduct a normal lifestyle despite being on optimal medical therapy. Now, if also the patient has rest pain, which is the first stage of critical limb ischemia, or has a non-healing ulcer, or has gangrene, which unfortunately is an advanced manifestation of critical limb ischemia, this time they have a clear indication for an intervention to restore blood flow or to improve blood flow. Now, what are the two main way that we have to restore blood flow? Either with a stent, as we can see here, the stent is passed, is crunched on a balloon and is passed into the vessel, and then the balloon is opened up and the stent keeps the vessel open after the balloon has expanded it. If the stent, however, is not working and or technically is not possible, we still have the surgery. And as we can see here, with the surgery, we use a graft, which is either one of the veins of the patient, which is the first choice, or we can use a graft made of dacron, which is this sort of artificial fabric that can be used. However, the first choice is still the vein, because the fabric, the dacron graft, is associated with overall poor patency, meaning is not likely to stay open for a long period of time. Okay, I will stop here for now, and I'm open to any questions.
Hi, Dr. Campia. This is Molly speaking again. Thank you so much. That was a great presentation. We do have one question to kick off the night. It is from a patient that sent it in via email. She writes, 2 years ago, I had a DVT in my right lower leg and acute thrombophlebitis. It was gone within 3 months. I stopped taking warfarin 4 months ago because of a bad cough and body aches. I continue to have redness around both ankles and feet, and both legs feel heavy. I had this even when I was still on warfarin. I had an ankle brachial index done a year ago. My doctor said the reason for it was claudication. My right ankle had an abnormal ABI of 0.89. My left ankle had a normal ABI of 0.91. The radiologist recommended a CTA. I had an MRA instead. The reasons given were PVD and abnormal ABI. The MRA result was normal in flow and 3 vessel runoff for both legs. Is it possible that I could have either PAD or PVD, even though the MRA was normal?
Yes. So first of all, this is a very common presentation of patients that have symptoms and have these sort of borderline ABIs. If you think about it, 0.89, 0.91 is a minimal difference. And unfortunately, we tend to consider 0.89 disease, 0.91 no disease. Actually, the patient probably has disease. Now, as I mentioned earlier, blockages can occur at different levels. So if the blockage occurs at the level of the aorta or the iliacs, the manifestation will be at the higher. If the blockages occur at the level of the thigh or at the level of the calves, the manifestation will be there. So the patient has peripheral artery disease, but one thing that may be occurring is that the MRI may not be able to detect small blockages in the vessels below the knee. The MRI is good, very good for the larger vessels, but sometimes for the lower vessels, it may not be ideal. So I think that this patient may have peripheral artery disease. One thing that I would recommend is to do the ABIs before and after exercise, because exercise is the best way that we have to trigger the changes in blood flow that cause the symptoms, and the ABI usually is lower after exercise, and that makes the diagnosis of PAD more easily and more accurately.
Wonderful, thank you. And then we did have another patient who's asked a question. They say that they had a DVT and PE 1 year ago, and they're now on Eliquis. What are the reasons for intermittent leg pain at rest? They have little to no symptoms while they're moving, either walking or working.
Yes, so the occurrence of symptoms in the legs can be caused by a number of different conditions. Normally, the presence of pain that occurs when walking and goes away when we stop is highly suggestive of the presence of blockages. The presence of pain at rest, but not when we walk, can be due to a number of factors, from some form of spinal disease. Sometimes herniated discs may cause that. Sometimes a narrowing of the passage of the nerves in the spine itself, what we call the spinal stenosis, can also cause this type of pain. Sometimes the pain can be due to muscle issues and not due to blood flow problems. Sometimes it can be due to the presence of what we called a cyst, particularly behind the knee. There can be what we call the Baker cyst that can compress the nerve that is nearby and cause the pain. So I would recommend that if the ABIs are normal, the patient should see maybe an orthopedic doctor or a specialist to see if there are other likely sort of hints of what is going on.
Thank you, Dr. Campia. And then another patient asks, should those over 65 be routinely screened for PAD by doing an ABI?
Okay, so this is a very important and somehow controversial question, in the sense that all of the experts in the field and the societies, the American Heart Association, recommend that screening. The issue is that we should not just consider this a screening, but should be considering it a diagnostic approach, in the sense that screening would be done just to prevent the occurrence of complications, whereas a diagnostic would be done to actively treat. Now, because above the age 65, as we saw, about 10% or people or more have peripheral artery disease, we are actually diagnosing it, not screening. Screening would be for a very uncommon disease that could be missed. In this case, we are diagnosing it. And definitely, patients at 65 should have once at least the ABI. And those who are 50 and older and have diabetes or have other forms of vascular disease, also they should be sort of tested or screened. Unfortunately, the preventive services, despite the efforts of our societies, have not yet approved the ankle brachial index as a screening, and therefore it's not reimbursed. And this is the main limitation. The doctors don't have the time to do it in their office, and they don't do it because they don't get paid for it.
Thank you. And then another question just came in, and this patient asks, is swelling in the ankle a sign of PAD?
Hey, can you repeat the question, Molly? Sorry.
Is swelling in the ankle a sign of PAD?
No. Peripheral arterial disease and all the sort of blood flow problems usually don't cause swelling. Normally what happens is that the patient that has peripheral artery disease often has other conditions that may cause swelling, such as a vein problem or such as heart failure, and they have both the swelling and the blockage. But the swelling itself is not a sign of peripheral artery disease.
Thank you. And then another patient wants to know, they write that they have a lot of pain in their leg after a DVT. Is there any connection between DVT and possible PAD?
So this is a very good question. So if we take a large group of people and we look at their risk factors for developing DVT and the risk factors for developing PAD, they have a lot of risk factors in common: inflammation, obesity, hypertension, diabetes. So both DVT and PAD are triggered, or the risk of developing them is increased. But having a DVT not necessarily increases the risk of PAD. The presence of pain in the leg after a DVT can occur acutely, but after a while should go away. If it recurs, or if it occurs with different features, not pain at rest or but occurring only when walking, at that point it would be appropriate to look for a possible blockage for PAD.
Great, thank you. We just had another question come in. She writes, should someone be concerned about nighttime Charlie horses that wake you up? Could this be a symptom of PAD or just an electrolyte imbalance?
Normally, those nighttime cramps are not related to PAD. Most of the times, the patients that have those cramps don't have blood flow problems. What can happen if a patient has severe PAD? They may have pain at rest, but it's not usually in the calf, it's usually in the foot. And it's very different. It's not the gnawing, the acute pain of a Charlie horse that is incredibly sharp and acute. Is this the pain in the foot from the blood flow reduction is very dull, is continuous, is very dull, as I mentioned. And usually it improves when the patient sits on the bed and put his feet dangling down. So they're very different, and Charlie horses usually are not due to PAD. One thing that can improve them is drinking tonic water before going to sleep, and it's because tonic water contains quinine and it seems to have an effect. And this is a sort of I would say funny personal experience. I was in Chicago and my uncle came to visit me from Italy, and he was mentioning that he had these cramps at nighttime when, you know, with in his calves, and I bought for him the tonic water, which he really likes, and he said that it did work very well. So at least anecdotally, it works.
Very nice, thank you. And then I think our last question of the night, unless anyone has any last minute questions, is someone asks if they have mobility problems, trouble getting around, and they can't really get up and walk a lot, what can they do to kind of keep their legs healthy and prevent PAD?
So, as I mentioned, PAD, the risk factors are the smoking. So avoiding smoking is really one of the most important ways to prevent. Avoiding diabetes. So if someone does not have diabetes, try to prevent. So keeping a good body weight, avoid eating a lot of fatty stuff. Then the controlling blood pressure. So if the blood pressure is high. In general, mobility itself is not going to cause PAD. Being active helps the whole cardiovascular system, so it's always advisable to do as much as possible. Obviously, if a person really has serious orthopedic problems, it may not be possible. But this is a very interesting fact that patients that have peripheral artery disease, so the legs, okay, blockages in the legs, and they do exercise with their arms sort of arm cycle ergometers, you know, that you can basically cycle with your arms, their symptoms improve in the legs, even if they are exercising the arms. So there is always a way to exercise the body that can help the whole system, even if you are exercising the arms instead of the legs.
Wonderful, thank you. And then we did have, it wasn't so much a question as much as a comment from one patient or someone calling in who says that if a patient has signs or symptoms of PAD and there's a normal ABI, then doctors should order an exercise ABI. And that this was recommended by the AHA 2005 guidelines. Is that something that you use?
Absolutely. And also we have more updated guidelines that were published in 2017. And the guidelines obviously confirm the recommendation of using the exercise ABI in case of symptoms with borderline ABIs.
Wonderful. Well, Dr. Campia, thank you so much for such a wonderful talk tonight. We all really appreciate it. I wanted to share with everyone that our next online support group will be in October, and Dr. Gary Raskob will be joining us to talk about World Thrombosis Day. Thank you everyone for calling in, and have a wonderful night. And thank you, Dr. Campia.
You're very welcome. Thank you, Molly. Good night, everybody.